Welcome to Doctors on Call. I'm Jenna Miller. Gastroenterology is the study of the normal function and diseases of the esophagus, stomach, small intestine, colon and rectum, pancreas, gallbladder, bile ducts, and liver. Common digestive problems cause millions of Americans to suffer daily and limit quality of life. Digestive problems can potentially result in symptoms such as bloating, diarrhea, gas, stomach pain, and stomach cramps. When is a colonoscopy recommended, and what is inflammatory bowel disease? We'll tackle these issues and more on Doctors on Call with our guest, family physician, Dr. Tyrel Somers.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from
Russell Regional Hospital, experts, neighbors, friends.
Our team at Smith County Memorial Hospital is always striving to exceed expectations of our patients and guests. Your family is our family.
Dr. Tyrel Somers received his medical degree from the University of Kansas School of Medicine in Kansas City, Kansas. He completed his residency at the University of North Dakota Center for Family Medicine in Bismarck, North Dakota. Dr. Somers is board certified through the American Board of Family Medicine and is a member of the Kansas Academy of Family Physicians, American Academy of Family Physicians, and the American Medical Association. His professional interests include chronic care management, gastroenterology, pain management, and psychiatric disorders. Dr. Somers has been affiliated with Russell Regional Hospital since 2015. Doctors on Call brings you information which may be useful to you when you see your own physician. Thank you for joining us again, Dr. Somers. We got lots to cover tonight, so we'll get right with it. So first of all, how do you know if something is wrong with your stomach?
Yeah, so the stomach is a very interesting organ because it exists like in different sections and segments that can all feel differently depending upon the individual. So the lower parts of the stomach sometimes can be referred on to the middle kind of sections and then move over to the right upper side of the abdomen. Sometimes you can feel discomfort, sometimes you can feel bloating, sometimes you can feel like a burning sensation. It all just depends upon what's going on. Another thing, sometimes you can feel it actually just epigastric, even moving over to the left side as well. And then finally, the very top part can actually feel and refer up through the esophagus. So you can sometimes feel it substernally, sometimes feel it around the heart area as well. So it's really kind of hard because the stomach, as compared to a lot of other organs, kind of has referred pain that can be in various different places and locations. So it's always important to keep it on the differential when you're working up someone with any kind of issue of pain, really anywhere from the navel all the way up until the mid-chest. You should always keep that in the back of your mind.
Interesting. Now, why would a person be referred to a gastroenterologist?
Yeah, so gastroenterologists have a really, really difficult job. Gastroenterology is kind of a very finicky specialty, for lack of a better term, because there's a lot of referred pain and there's a lot of kind of processes that occur within the stomach that require very advanced testing and very advanced treatments. It makes it very, very tricky for some individuals to navigate, especially family medicine doctors or primary care providers, because there's a lot of specialty testing that occurs with it. Gastroenterologists are often brought in for that. But on top of that, too, the management of a lot of liver-based diseases, the management of a lot of the gastroenterology diseases require special medications, special type of treatments. And so because of that, the gastroenterologist is necessary to help facilitate those treatments as well.
And what do you tend to see come into your office?
So the most common thing that I see come into my office is one of two things. It's just generalized abdominal pain, discomfort that can be brought on by a lot of different things. The second thing that I see, though, is a lot of gastroesophageal reflux disease, which is a kind of irritation of the stomach itself. And the most common reason why people have it is use of over-the-counter medications to help with pain, like Tylenol, ibuprofen, those kind of things can cause some problems with gastritis and irritation in the stomach. And so getting treatment for that I see often as well.
And going back for a second to the referral, does a patient, if they need to see the gastroenterologist, do they actually need a referral from their primary care?
Yeah, for the most part, a gastroenterologist is required a physician referral, or at least an advanced care provider referral. And that would be given by any kind of medical specialty that would be in primary care.
Excellent. Okay, let's talk a little bit more about irritable bowel syndrome, what it is and what a person can expect.
Yeah, so irritable bowel syndrome is a very interesting process because as compared to most other abdominal diseases, irritable bowel syndrome is kind of characterized by a discomfort that's either followed by constipation, followed with diarrhea, or just happens all in of itself. It's kind of a catch-all term for a type of gastro disease where we're not really 100% sure what the origin is, but all other workups have been kind of excluded. So we call it a diagnosis of exclusion specifically. It's often helped by medicines that help relieve symptoms rather than a specific treatment. For example, like if you have high blood pressure, you give a medicine that reduces blood pressure that fixes that problem. With irritable bowel syndrome, we're instead kind of helping with symptoms, abdominal cramping, abdominal bloating, those things, not really finding the exact source of what's causing it.
Sure. And what is ulcerative colitis?
Yeah, so ulcerative colitis is one of the two forms of inflammatory bowel disease.
Okay.
It happens in the very distal portion of the abdominal tract itself. So at the very end of the digestive tract, at the rectum, and then moving upwards. It's characterized by very, very frank areas of inflammation that cause tissue breakdown that can lead to bleeding, discomfort, can lead to weight loss, can lead to a lot of complications, and has to be managed by immunotherapy and other types of treatments. So it's very advanced and very, very concerning to have.
Sure. What about Crohn's disease?
So Crohn's disease is the other half of the inflammatory bowel pathway in the digestive system. Crohn's disease is kind of characterized very similarly in that it's an inflammatory process that happens in the intestinal wall itself, but instead of starting at the rectum and moving upward, it instead skips, so it has these skipped areas. The one hallmark, though, specifically is it's always found within the terminal ileum, which is the very end part of the small intestine. So often, in order to make the diagnosis for both ulcerative colitis and Crohn's disease, you have to undergo a colonoscopy so that you go in and find the tissue that's inflamed and retain a biopsy or sample of it.
Okay. Well, let's talk about that colonoscopy, what it is and what people do or do not have to fear.
Yeah. So colonoscopy can be a very concerning process, and it's one of the most important screening tests, but also diagnostic tests that a physician that's trained in gastroenterology and or a general surgeon or even a family medicine doctor like myself can do. It's a scope that's about the diameter of my forefinger, so it's not a very big scope, but it's very long. It's supposed to designed to go from the rectum all the way to the very starting point of the large intestine, which we call the cecum. It's kind of used with carbon dioxide or air to inflate the actual colon wall itself so that you can look through and see it, because at the very end of it is a camera that's in high definition so that the doctor can see everything very well. It's got a central channel that you can pass tools through so that you can obtain biopsies, samples based upon what you see. It's very, very important in screening because if we see colon polyps, we can intervene very early and remove colon polyps before they become colon cancers. But there's a lot of advanced treatments that can happen through a colonoscopy itself. You can actually do like tattooing, which is marking where like colon lesions are at, so that you can either maintain them, look at them, or even tell surgeons, hey, I saw the lesion between this mark and this mark. That's where the lesion of concern is. That could be a cancer that needs to be removed. There's a lot of different techniques, and colonoscopy is really, really important to look at the diagnostic and screening aspects of gastric health.
Sure. Now, how have the colonoscopies changed, even since you've started?
Yeah, so colonoscopies changed quite a bit since I started learning it. The invention of high definition was a huge thing for colonoscopies. At first, it was just a standard camera that was used. But even before then, doctors used to have a series of like mirrored lenses that they would look through a scope kind of like this, almost like a microscope. And you can imagine bending over, doing that with a patient near their backside is very, very challenging. But now that we have the cameras, it's very nice. We look at a TV screen. It's almost like we're playing a video game, for lack of a better term, in someone's colon. But allows us to use full rotation, full movement. Another thing that's been a huge addition is the use of carbon dioxide rather than air. A lot of the times when we were using air when I was training, it caused a lot of discomfort, especially when the person would first wake up and they'd have to pass gas in order to help get rid of that. With carbon dioxide, it absorbs so quickly that when a person wakes up, the discomfort isn't really there as much as it used to be, and it makes it so it's a lot easier to do, but it's also a lot easier to convince the patient, hey, in 7 to 10 years when you need a repeat one, come back and see me. It's a lot easier to do. So.
Well, you may have come up with something new with the colonoscopy video game.
Yeah,
you
exactly.
might want to look into that. So let's. What can a patient expect when they, especially one that's maybe a little nervous about having this done or is putting it off? What do you tell them?
Yeah, so a colonoscopy is really is an easy medical procedure. It's normally a same-day procedure. You're going to have a prep the day before, and that's by far the worst part if there's any of a colonoscopy. A prep is typically given with a solution or with a series of tablets to help you go to the bathroom and clean out all the stool that you can so that we can get a clear and precise picture. But it's really important to do it. It's not fun, but it's definitely important, because if we don't see in good clarity what's going on, we might miss important polyps, we might miss important details that we normally would see if you have a nice clear colon prep. So if there's one thing you can do to help the physician more than anything else before a colonoscopy is make sure to take that prep seriously and try your best to go all the way through that prep and get yourself fully cleaned out, because that will make it so much easier for us to see everything in detail and take care of you. Once that's done, for the majority of the time, we just put people to sleep in our facility. You basically go to bed like you're having a nap. You wake up and everything's pretty well and done. The total procedure takes anywhere between about 15 to 25 minutes, so it doesn't really take that long. And we get tons of good pictures, tons of good information. And if we find polyps that we can intervene on, we're probably preventing you from having colon cancer later in life, which can be life-saving.
Sure. And who is a good candidate for colonoscopy?
So yeah, colonoscopy should be done in every individual that's over the age of 50, according to the United States Preventative Task Force. The American College of Gastroenterology recommends for certain groups to do that even earlier, 40, 45, depending upon risk factors. But for the vast majority of people, once you hit about 50 years of age, you should be thinking about getting a colonoscopy and talking to your primary care provider specifically about it. If you do have a family history or more high risk, your primary care provider should be able to identify those things and help you get into colonoscopy even sooner than that, though.
Sure. And you might talk briefly about the risks that might be involved.
Yeah, so the biggest risk for a colonoscopy specifically is with perforation, which is poking a hole in the colon wall. For most people that are younger, like in their 40s and 50s, that risk is very minimal. But as you get older, your colon wall, just like your skin, becomes thinner and thinner and thinner, so the risk of perforation goes up. That's why at 75 years of age, we typically say screening isn't really as necessary at that point. It's not really going to give you the benefits that it would for the risk of undergoing it. The next big risk is with bleeding. If you take a lesion off or if you biopsy something, of course it's going to bleed. It always does. And for the most part, we stop it there within the facility before we ever send a person out. But if they're on like a blood thinner or they're kind of prone to bleeding and the scab that we made kind of falls off prematurely, bleeding can happen once again. And so repeat colonoscopy might be necessary for those individuals, unfortunately.
Okay, let's talk about what gallstones are.
Yeah, so gallstones are very specific stones that develop within the gallbladder themselves that most of the time are not harmful until they can get either to the ampule, which is the area where the gallbladder empties, or into the common bile duct, which is the duct that carries bile from the gallbladder down into the first portion of the small intestine.
Okay, and what are the causes? How are they treated?
Yeah, so the causes of gallbladder disease can happen for a number of different reasons. It's typically dietary. People that eat diets that are high in like saturated fats, that eat specific types of very kind of rich foods can kind of increase your risk for it. Typically individuals that are a little bit heavier, like myself, are a little bit higher in risk for it. It normally presents as kind of right upper quadrant discomfort that happens after eating, especially a big fatty meal, that doesn't typically go away except for with time. So you normally have to wait anywhere between about 7 to 10 minutes for it to finally start to subside. As it gets worse, the length of time before you start getting pain and the amount of time that the pain lasts for becomes longer and longer and longer. And that's when evaluation by a surgeon is necessary to see if you need to have your gallbladder removed.
Sure. And while we're on the topic of food, how do you feel about what can be cleared up just by a person cleaning up their diet?
Yeah, so diet is a massive part of what we've kind of explored with gastroenterology in the last like 20 years. Like we've learned much more about the human microbiome and how it works when it comes to our own kind of gastric health. We're focusing a lot more not just on probiotic treatment, but even now prebiotic treatment, which is this idea that if we eat foods that are rich in kind of fermented things, rich in bacteria, it might help increase our bowel health and help us be able to better fight disease, to have better kind of bowel movements and less risk for obtaining irritable bowel syndrome or other complications that can lead to worsening bowel health.
Okay, very interesting. Well, we have got a caller waiting to ask a question. We're going to go to the phone lines now. We've got Sarah on the line from Waukene. Hi, Sarah. Go ahead with your question for Dr. Somers tonight.
Good evening, Jenna and Dr. Somers. I was wondering if you have any suggestions for what I could do for a bloated stomach that I believe has been triggered by stressful events happening in my life.
So fantastic question, Sarah. Thank you for asking that. So stress plays a massive part in colon health and in bowel health. We know that there are specific receptors within the bowel that are very similar to the receptors that are within our brain that help control kind of anxiety and depression. The biggest thing that I would tell you to help with that is to find treatment for your depression, anxiety component if you haven't already sought those, because that typically helps reduce some of the bloating sensation that's there. Another thing too that can really help is trying to minimize some of the things that might trigger your bloating in your diet. Carbohydrates, especially very dense ones, can make you feel a little bit bloated. And for some individuals in America, lactose-containing things or kind of really heavy gluten-containing things can make them feel bloated as well. So decreasing the amount and or eliminating those sometimes can be helpful as well. But by far, I would say if it's really stress-related, getting that stress treated with either medications, counseling, or any number of things would be very beneficial for you there. Thank you for your question.
Yeah, that's a great question. And she mentioned that she believes that it's the stress that's causing it. How do you know? How do you know when that's what it is?
Yeah, that's the hardest thing. And to be honest with you, as a physician, typically what I do is I might make that suggestion to a patient and say, hey, this all could be stress related and stress mediated. In which case, if we treat your stress, maybe that will make your symptoms better or more manageable. Why don't we give that a try and see, and then have them come back in a short period of time, 2 to 3 weeks, and say, how are things? Now that we've treated this stress, is A, your stress better? Because that's item number one we want to correct, but how are your bowel symptoms coming along? I would say about 60% of the time, and that's just an estimate, people are better with both if they treat them aggressively and meaningfully, which I think is beneficial for them.
Excellent. Okay, we've talked about the colonoscopy. What about an endoscopy? What is that?
Yeah, so an endoscopy is an upper scope. It's got a really long, fancy name, esophagogastroduodenoscopy, or an EGD is another term for it. It's a very smaller scope, about the diameter of my pinky this time, and much shorter. But it goes in through your mouth, down through your esophagus, and into the stomach and first portions of the small intestine. It's a really nice test to help diagnose any kind of upper gastric issues that could be going on, like a gastric ulcer, problems with gastritis, irritation. It looks for esophageal cancers. It can look for stomach cancers. It can look for areas within the very first portion of the small intestine that might be irritated because of gallbladder disease or other absorption diseases. So it's really, really important. As compared to colonoscopy, it's got risks in regards to being near the airway. So when you're going down, you're right next to where the airway is at. So you want to make sure that you're not accidentally going into the airway or getting near it, especially if you're using carbon dioxide as a inflating mechanism. You don't want to be pushing carbon dioxide within the lungs. That can be a bad thing. And then, of course, bleeding. Just like with the colonoscopy, we're taking biopsies, we're taking samples, they can bleed. They'll stop when we're in the operating room. We'll stop those from making anything come through. But if you're at higher risk for it, you might start bleeding from it.
Sure. And what patient is a good candidate for this procedure?
Yeah, so a lot of different patients can do endoscopy. I typically do my patients who have like recurrent episodes of gastritis, people who have very focal discomfort and pain that I think might be coming from a gastric ulcer, people who have kind of recurrent, so they've had gastritis in the past, they come again for another episode and again, and they just have like this waxing and waning course. So any of those are really good. If you have an individual who has higher risk for varices, which are kind of blood kind of collections within the actual esophagus, so people who have liver disease, alcoholism is another one that can cause it. Looking at those and seeing if they're at risk is another person that you'll do. And then, of course, people who have problems swallowing. If you have like an issue as you're going down, you can see that on the endoscopy, and sometimes we can clarify if it's being caused by scar tissue or strictures or any number of things that can cause problems with swallowing.
Sure. All right. We want to remind our viewers that we are talking about gastroenterology tonight with Dr. Tyrel Somers from Russell Regional Hospital. Let's talk about how common is chronic constipation.
Yeah, so constipation can be a very detrimental thing for individuals that suffer from it. How common it is, I don't have the exact statistics for you, but I would say in my practice, I see anywhere between about every 3 to 4 people out of 10 have problems with constipation at some time in their life. Constipation can happen for a variety of different reasons. One of the most common things I see is it's medication induced. So you have medications that are causing you to have dryness in your mouth. They can also cause dryness in your stool that can then lead to constipation.
Sure. And on the other end, what about loose bowels? What can a person do about that?
Yeah, so diarrhea can happen for a bunch of different reasons. Loose stools can occur primarily because of medications. It can be because of illness. It can be because of irritable bowel syndrome. It can be sometimes because of inflammatory disease. So getting an evaluation as to what's causing it, it's really important. As compared to constipation, one of the first keys in a good diarrhea workup is to obtain stool sample, which can be a very problematic thing for people, can be very anxiety producing, but it gives the physician or the provider a ton of information. And so it's really, really important if you can to provide that sample for us to look at.
Okay, let's talk about lactose intolerance. Seems like that has gotten some steam this last few years. What is it and why?
Yeah, so lactose intolerant is very common in individuals of like Northern European kind of descent. And it causes issues when they turn anywhere in their middle to lower 20s. They start having problems digesting lactose specifically because they're missing a very specific enzyme that digests it completely. Most of the time they have a lot of bloating. I kind of mentioned to our caller earlier that sometimes reducing that can make a little bit of difference. Sometimes they have abdominal cramping, discomfort. Sometimes they get really like loud abdominal sounds, gurgling, things like that can be distressing to them as well. Reducing down lactose within your diet or eliminating it completely can be beneficial, but as of late, we have made huge advancements in getting lactose-free products, or even having like a lactose aid that can be digested and eaten before consuming lactose to help reduce those symptoms. And they've been beneficial for a lot of people.
Excellent. Now, can blood tests detect digestive issues?
So there are some blood tests that we do for digestive issues, and they're really important in evaluating people for chronic abdominal pain. Unfortunately, a lot of the very specific diseases that we've talked about today, inflammatory bowel disease, irritable bowel diseases, don't have specific lab tests that say, this is what's causing it. It's kind of one of the unfortunate things about gastroenterology that makes it difficult too, is a lot of the times we're looking at more kind of processes and getting history on top of some kind of standard tests to figure out what's going on, but there's no specific tried and true, if I get level X, it means disease Y, unfortunately.
And what can you tell us about celiac disease?
Yeah, so celiac disease is a very specific process that happens with gluten and gluten processing. Gluten intolerance versus celiac disease, though, I have to give you information, are two separate diseases. Gluten intolerance can happen with a lot of individuals. If you have a problem where you feel more full, more bloated because of eating gluten products, it might mean that you have a gluten intolerance, but not specific celiac disease. That's a very specific inflammatory process that happens to individuals because of the consumption of gluten that causes allergic reaction. It can cause a lot of other detrimental problems. And honestly, if I see a patient who truly has celiac disease, it has to go to management for a gastroenterologist just because it's not very common, whereas gluten intolerance is a much more common process.
Sure. And how do you test for it?
Celiac disease is actually one of the ones that we do have a very specific test for, and there's a blood test that can be done to check and see if you have the very specific antibody to that gluten process, and it's a simple blood disease. As part of a workup, if I have a person who says that they have a hard time, it's almost always one of the labs that I draw with it just to be on the safe side.
Okay. And what is acid reflux?
Yeah, so acid reflux happens within the stomach itself when it overproduces acid, either because of stress, can be because of diet, it can be because of disease, specifically infectious disease, or it can be because of medication. Any of those things can cause it. But that overproduction of acid then causes irritation within the stomach, that causes discomfort, pain, and then even cause issues with reflux kind of going upwards into the esophagus and causing burning pain going up the esophagus as well.
Is it something that you medicate just to cover the symptoms, or can it be cured?
It can be cured for sure, depending upon the source of what it is. There's a very common bacteria that can cause recurrent reflux that I was talking about when we were talking about endoscopy, called H. pylori, that if it's discovered can be treated with 3 different medications or sometimes 4 different medications to make sure that we eradicate and get rid of it. That's completely curative and does a great job if you have it present. Unfortunately, it's not very common to find it in individuals without that history, so it's hard to say. If you have a gastric ulcer and it's treated that was causing your reflux, it can make a massive difference and can really help minimize your symptoms. But for some people, they're just kind of more prone to reflux disease, and so staying on kind of a chronic treatment just always helps keep that minimized and keeps it manageable.
Sure. Now, is there risks if a person goes without treating it at all?
There's not really any risks other than the discomfort that comes from it. And a lot of the times that discomfort can be quite debilitating. So I find the vast majority of people will treat it regardless. But no, there's no risks with it. The big risk right now is we're learning more and more about one of the specific classes of the medications used for treating, called proton pump inhibitors, where it may cause problems with calcium absorption that might lead to osteoporosis, thinning of the bone later in life. We're also learning that there might be a slight risk between it and dementia formation. And so long-term use of a proton pump inhibitor may not be as good as we used to think it was in our treatment standpoints. So a lot of physicians have turned from using those as primary treatments to trying to use other medications like a H2 or histamine type 2 blocker to help reduce acid formation.
Sure. We have just a little bit of time left. Is there a difference between acid reflux and heartburn?
No, heartburn is more the symptom that happens with it. Acid reflux is the actual disease process.
Okay, excellent. Well, thank you so much for being our guest again tonight, Dr. Somers from Russell Regional Hospital. We were speaking about gastroenterology this evening. On our next Doctors on Call, we'll be discussing cardiology. You can email questions to us for our next program. That address is doctors@shptv.org. Thank you for joining us for Doctors on Call. I'm Jenna Miller.
Presentation of Doctors on Call on Smoky Hills PBS is made possible in part by an underwriting grant from
Russell Regional Hospital. Experts, neighbors, friends.
Our team at Smith County Memorial Hospital is always striving to exceed expectations of our patients and guests. Your family is our family.